So I'm happy to have our next speaker with us, Henning Blume. He has important functions within the EUFEPS and as well in this regulation, especially for bioequivalence. And I think that is a topic which has been addressed by the speaker. So looking forward to your presentation. Thank you.
Thank you very much, Stefan, and thanks the organizers for inviting me to join this important session today. And I was asked to summarize and present some conclusions of the last conference on global Bioequivalence Harmonization initiative. That's an initiative started by EUFEPS some years ago, and it's my pleasure to chair these conferences. And we have every 18 months a conference, once in the US, once in Europe. We started in Amsterdam in 2015, then 2016 in Rockville, Washington, and the previous conference was in April this year in Amsterdam again, and the next one will be most likely October next year in Rockville again. We have an international planning committee. I'm very happy that we have full support by the Pharmacokinetic Working Party, which has already been mentioned from EUFEPS, and also Thomas Salmonsen, the chairman of the CHMP. He supports this initiative significantly, and also US FDA, and we are happy about that. That is the background why I said I know how difficult harmonization is, and you need to define those issues to be discussed where you see a realistic chance. It's very easy to pick up the issues where there are significant differences, and you will have no chance to come to a consensus immediately. Therefore, it's a long way to go, and I am happy that we started this process and came to some conclusions. I have no disclaimer, but I present, of course, my own view on the topics. Of course, I include the discussions and the outcome of the discussions during the conference, but I like to challenge the regulatory authorities' position in one or the other point. And we discussed in particular on the liposomes, and that was really interesting. When we suggested to take up the liposomes issue in bioequivalence assessment in the last conference, the immediate response from both sides, US FDA and EMA, was, no, we did not define our position clearly. And my immediate response was, yes, that's what a situation which I like to have, because if everything is written in stone, it's a nightmare to dissolve the positions and come to some harmonization. Therefore, I was very happy that after a long debate, we took up that point. And these are the two main topics which we discussed. One is which analyte should be measured, and that's my topic today. And the other one was the body surface area related dosing, because here we are in a clear situation that there are no significant differences, and therefore I will not go much into details here. The current regulatory thinking was difficult to define when we started this process. However, in 2017, this was already said, and US FDA product-specific guideline or guidance has been published, and the outcome was that the analytes to be measured to establish bioequivalence assessment based on those are the encapsulated doxorubicin and the non-encapsulated, so-called free. I will also use the free, even though it's not free, it's protein bound, but it's free means non-encapsulated. We had also a debate on that, and scientists always look into the details and say, no, it's not free. Well, I use that terminology, free, and you see here encapsulated doxorubicin and free should be measured. And this requirement was challenged during the discussion. Is that really necessary to measure both to establish bioequivalence on that. And that's my topic. Where is the scientific rationale for such comprehensive requirement? And is there really, and that's the essential question, is there really a risk to fail bioequivalence for the free doxorubicin if the encapsulated has been shown to be bioequivalent? That's the main issue. If there's no risk, then why to measure the free and establish bioequivalence based on that as well? So the main questions are, first of all, are both analytes independent pharmacokinetic characteristics? And that's my main aspect. Are they independent or are they determined, one out of the other? And the other question is the reliable determination of free doxorubicin, because you have to separate the encapsulated and the free by solid phase extraction. And of course, it is possible to come to some disruption of the liposomes, and so that's a really difficult question, and most likely the difficulties, and in particular variability, is due to the complex analytical procedure involved. So that's my first slide, and Gabizon, he is a pioneer on that field in terms of clinical characterization, and this is one of the main slides out of his presentation and his papers published. And you see here the solid line is the total doxorubicin. The dotted line going directly in parallel is the encapsulated, and that is the free doxorubicin. And there is, let's look a little bit more in details. First of all, you see these 2 or 3 curves, they decline very much in parallel. And that's an essential finding. They are in parallel. Looking a little bit more in details, first on liposomal preparation, which has been approved, and this is not a pegulated liposomal preparation, and therefore release occurs much more rapidly. And you see here the decline of the encapsulated, and this is the non-encapsulated, the free doxorubicin, and they measured doxorubicinol, which reflects the free because the metabolism is only possible after release from the liposomes. That's the concept behind. And again, the curves decline in parallel. So please understand this slide, and please have that slide in mind for the other discussion. It's now the comparison of the 2 liposomal doxorubicin preparation, the pegulated liposomes, that's Celix, or the non-pegulated, that's Myosid. And you see here again this decline, and here the free doxorubicin. And the main difference is the free doxorubicin is eliminated very, very, very rapidly with a half-life of 10 minutes only. And the release from the liposomes occurs with a half-life of around about 50 hours. So the question is, what is the controlling or rate-determining process? If there is some release of free doxorubicin, which is, of course, not only efficacious in terms of efficacy, but also toxic. And therefore, I understand the concern, and authorities, sorry to say that, always want to be on the safe side. And that's, of course, understandable. And therefore, they are so critical concerning the free doxorubicin. However, it has a half-life of 10 minutes only. And why this half-life and why these differences in the profiles? This is obviously, and that you can read that also in Gabizon's paper, this is obviously the release from glycosides. So the free doxorubicin is taken up by leukocytes and then released from that as well. And if you see, oops, that was too fast. Sorry for that. If you compare the profiles again, that is 50 hours, that is 50 hours. Obviously, the release controls the entire process. So there is convincing evidence that the release is the controlling and determining process, and we are here in the classical situation of a flip-flop kinetics. So the pharmacokinetics of free doxorubicin is controlled by the release from the liposomes, and the final elimination is from this deep compartment, and the leukocytes are part of that. The conclusion is that BE demonstrated from encapsulated doxorubicin should guarantee the bioequivalence of free. That was the conclusion suggested in the conference. However, final evidence should be derived from failed study, and that's a problem. We don't have failed studies in the public arena, and often, even though it should be submitted, authorities also don't have the failed studies. But these were, in my eyes, the most convincing evidence whether this concept holds or not. Are there examples where the free doxorubicin failed and the encapsulated passed? Not just because of variability, because that can also be analytical derived. And the suggestions and expectations of the conference was that the requirements should be revised, encapsulated only. And I left Amsterdam with the impression that EMA seemed to consider this, and FDA was more reluctant. And therefore, I was a little bit surprised when earlier this year, this draft guidance, also product-specific guidance of EMA was published, and see the analyte encapsulated and non-encapsulated. From a harmonization point of view, it's fine, because both have the same requirements, but from the scientific point of view, I'm not sure whether this is the right way to go. Are these really science-driven regulations? Why argumentation presented is not considered, and are there contradictory findings? And my suggestion is follow the bioequivalence principles. And now my last and probably strongest argument. The basic principles of the bioequivalence concept, the global bioequivalence concept, developed for orally administered drugs primarily, and then extrapolated to other dermal and whatever, transdermal. The goal is, in bioequivalence assessment, to show equivalence in drug release from the product in the GI tract. And that is also very, very complex. Gastric emptying has an impact, and it's not just the release from the dosage form, but also the question at what site in the GI tract the release occurs, because absorption is different in the various sites. Normally, there's a tendency to reduce absorption from a more distal part of the GI tract and not from the more proximal. And the rationale is to conclude from plasma profiles to parent drug. That is of the parent drug, because the parent drug is very close to the dosage form, and therefore parent drug is more important than metabolites, etc. Now, what is the situation here? It is a totally different situation. In the oral scenario, we don't see the dosage form. We conclude from plasma profiles on the performance in the GI tract. But here we see the dosage form. Here we see the release from the drug product, from the formulation, from those particles which are relevant for the release and the delivery of the active. So we see the release from the dosage form, and that is the decline of the encapsulated doxorubicin liposomes from plasma. And therefore, my conclusion is that the encapsulated compound in plasma reflects products biopharmaceutics and therefore should be determining for bioequivalence assessment as it is determinant for the pharmacokinetics of the free doxorubicin. That's my main argument at the end, and I will of course comment on the draft guidance, also making them aware there is a bioequivalence, a global bioequivalence concept, and this should be applied here as well. So thank you very much for your attention, even though I have 28 seconds. 28 seconds more.
Thank you very much for this very nice presentation, Henning. And I can just mention he will be a speaker as well in Budapest. And if you want to continue a little bit the discussion after today, please come to Budapest. I have a few programs here. Urgent question. Yes, Marisa.
Just as like a question to be considered. We recently have seen in early scientific advice liposomal formulation containing known analytes, but there's so much innovation in the way the active is bound inside the liposomal formulation, which is really very, very innovative and is something which I'm not sure would accommodate for the scheme you presented. I think this may be one of the reasons why, in spite of being inclined to facilitate simplified dossiers based on bioequivalence, nevertheless, I think there are uncertainties. Once you go out with a guideline on liposomal parenterals bioequivalence, then you should try to encompass all variables. And I'm not sure that what we've seen recently, end of last year, beginning of this year, as a new technology within the liposomal formulation would be served by the approach you described. I mean, I don't know. I have not seen yet the dossier. It has not been submitted for marketing authorization. But I think that could be one of the reasons whereby the committees now are a little bit more prudent. And I think it's easier once you have a general guideline to discuss and maybe be waived in an early scientific advice eventually, rather than be confronted with someone who comes, okay, you asked for that, I give you that, why you don't accept now? In the case... Yeah.
Marisa, your point is well taken, and I understand the background of your question very well. Sometimes I try to make my life easier, and I did it this time in two aspects. First of all, I was only talking about doxorubicin, only. Second is I was only talking about bioequivalence and not CMC aspects and structure, particle size, etc., etc. Very important aspects. I didn't talk about that. And it is really obviously a case-by-case situation in the liposomal preparations. And I have one backup slide, probably later in the discussion. That's the classification system suggested by Su and Huang from Taiwan. And they combined certain aspects and came to the conclusion, and they made Monte Carlo simulations and came to the conclusion that in those classes where doxorubicin liposomal pegulated preparations are allocated to, it is very obvious that the encapsulated analyte is more sensitive to detect differences between products than the free doxorubicin. And other active ingredients, other not encapsulated in the core of the liposomes, but in the shell, so to say, they are different. So it's really here. This is something where we do need product-specific guidances.
Okay. Thank you.
Yeah.
There is one other question, and then we will move on.
This is more scientific, related to the physicochemical properties of doxorubicin. I mean, doxorubicin, which we all know is an alphaphilic compound, and it's forming a lot of aggregates, which is influenced by both internal factors within the liposome as well external factors outside the liposome. So have you considered, even if the encapsulated formulation, the liposome, behaves similarly, you may still have different aggregation of doxorubicin within the particle that might affect the release. And that's why it still might be, as EMA stands here, a need to measure the free release, because even if the liposome itself behaves BE, bioequivalence, the aggregation of doxorubicin, very complex molecule, inside the formula might affect both drug load and drug release. Have you considered that in your discussions?
Yes, we considered it in so far that we say that is part of the characterization and the stepwise procedure to compare the quality attributes between test and reference formulation, and then you would see differences in these aspects which you mentioned, which are very important. However, again, first of all, if there is some more rapid release of the free, half-life 20 minutes, it is very rapidly eliminated or bound to other structures, etc. And if there is a difference in the release from the liposomes, then you should see it also with the encapsulated. But of course, that's then we say, yes, a little bit a theoretical assumption, because we do not have seen studies which show differences.
The 10 minutes half-life, that's the distribution half-life you're talking about. That's not the terminal half-life.
Yeah, sure.
Yeah. So
absolutely. Yeah.
So the half-life is just the distribution half-life. You're not talking about the terminal half-life.
No, the terminal half-life is going in parallel, as we saw, 50 hours half-life. That is a very complex combination.
But if you would have a boost release, so to say, the larger release of the formulation for some reason, you will see a distribution, and then you will go on to, because then you release sufficient amount of drug, so then you will have a terminal half-life as well, determining the AUC, which will be very, very important for a bioequivalence assessment.
Yeah, I see your point. So it may be that there's a larger quantity bound somewhere and released with the terminal half-life, however, on a higher level, and this may be efficacy or safety related. That's a point. So the question is whether you see that burst release or more rapid release from the encapsulated profile as well, and our conclusion was, yes, we should see it there. But again, I would like to see failed studies showing differences, but so far they are not present. And I think one reason for that is that this comparability exercise makes it very clear that the formulations are very similar. But your point is very well taken, and I cannot really respond by giving you evidence for that.
Okay, thank you very much. We are in the middle of the discussion, but I think it shows nicely how complicated all these drugs are, and I'm happy now